Good afternoon, everyone. Just want to welcome you to this GECO session, which is hosted by the Gastro Foundation and Project ECHO from the University of New Mexico. As you know, it's every Monday at 4:30, and the chat will be open for questions. And I'm not sure how many of us there are going to be, but quite happy for you to stop me actually during the talk, and we can just chat about it. I'm going to just talk about cholangiocarcinoma in general, and it's quite a broad topic. So I want to try and give like a practical approach that's going to be useful in an exam. So starting off, it's a very heterogeneous group of tumors. There's a marked geographic variation, and that is thought to be due to differences in the incidence of risk factors in different parts of the world. For instance, there's areas in the east, like Thailand and Japan, that have very high incidences, and that's thought to be due to the incidence of various different types of liver flukes. In the last decade, things that have changed, I think, are a better understanding of the different subtypes and molecular alterations. And I think in the next 10 to 20 years, there's going to be, I think, quite a lot of improvements in biologicals and immunotherapy for different types of these cancers. There's been an improvement in the diagnostic modalities, and I'm thinking specifically of cholangioscopy that allows targeted biopsies of these lesions in an endoscopic ultrasound. And there's also been an increase in the treatment modalities that are available. So liver transplantation is now sometimes considered for hilar cholangiocarcinomas, and I think there's a increased understanding of which chemotherapy agents and work. So I remember when I was studying for the certificate exam, then it was a written exam, and this was something that we'd often get asked. It was on cholangiocarcinomas, and you can classify them different ways. But the first and most important way is according to the site. So about 10% are intrahepatic, about 60% are hilar, and 30% are distal. And the points that differentiate them are the second order bile ducts. So anything proximal or to the second order bile ducts would be considered intrahepatic. From the second order bile ducts down to the cystic duct is hilar, and then distal is below the cystic duct to the ampulla. This works quite well, except when you have a low entry cystic duct. So I think if you have a low entry cystic duct, an alternative would be to say within 2 centimeters of the confluence. Then you can classify them according to the macroscopic growth pattern. So when it comes to the intrahepatic type, there's mass forming, which makes up 60 to 80% of the intrahepatic type. There's periductal infiltrating, which makes up 15 to 35% of the intrahepatic type. And then there's intraductal, which makes up 10 to 20%. If you're taking the hilar and the distal ones, they don't have, the mass forming is only for the intrahepatic type. So the hilar and the distal ones are either periductal infiltrating or intraductal growing. So the mass forming ones for the intrahepatic, they have a firm, solid, they're firm and solid. And if you on the cuts, when they cut, they have like a white, gray appearance. On imaging, there's often surface retraction. There may be central necrosis that sometimes can give the appearance of a central scar, and there can be metastatic lesions elsewhere in the liver. The periductal infiltrating ones extend along the bile duct. They present sort of as a narrowing or just a stricture. And there's often quite a lot of infiltration into adjacent structures, which might be the portal vein or hepatic artery. And then the intraductal growing one often have a papillary or polypoid growth pattern. I think these are the ones that you're most likely to get a positive diagnosis when you do brushings. And they're thought to potentially have a better prognosis than some of the other ones, the other types. So then you can classify these things histologically, and you get the conventional sort of cholangiocarcinoma that is a normal adenocarcinoma, and they can be divided into well, moderately, or poorly differentiated. And then you also, the conventional type gets divided further into the small duct and large duct type. So the small duct type is only going to be in the intrahepatic group, and the risk factors for the different types are different. So the small bile duct type would be more common in patients with hepatitis and cirrhosis. Those are risk factors for the small duct type. The large duct type, things like liver flukes, chronic inflammation, intrahepatic stones, are more likely to cause the large bile duct type. And then you get rare types, of intrahepatic cholangiocarcinomas, and you can even get an HCC-like cholangiocarcinoma where there's components of cholangiocarcinoma and hepatocellular carcinoma. So there's different, you can use a TNM staging system, but for the Hilar cholangiocarcinomas, we often use the Bismuth-Corlett classification system, and it's similar to the Strasberg classification system that's used for bile duct injuries for the E-type. So type 1, the confluence is intact. Type 2, there's separation of the right and left hepatic types. Now, this is not actually correct. Type 3, the tumor goes right up the right hepatic duct and blocks the second order duct. So it should be extending right up to the second order ducts. Same with the type 3B, that should be extending up to the left. Type 4, it should be extending up to the sectoral ducts bilaterally, and type 4 can also be multicentric. Okay, so that's the Bismuth classification, and that's something that I think you do need to know. Looking at the risk factors, so primary sclerosis, so there's definite risk factors, and I think in our environment, primary sclerosing cholangitis is a big one, and another one is hepatolithiasis and biliary malformations, which include choledochal cysts, Corelli's disease, congenital hepatic fibrosis, and a long common channel is also thought to be a risk factor. Liver flukes are common in some parts of the world. We've only ever come across, I think, 2 patients that I know of in Cape Town that have had liver flukes, and both of those patients were from Knysna. Thorotrast was a contrast agent that was used, I think, in the 60s, and had quite a strong association with the development of cholangiocarcinoma. Cirrhosis and liver disease generally are risk factors for developing cholangiocarcinoma. Obviously not to the same extent as hepatocellular carcinoma, but there is an increased incidence of cholangiocarcinoma in those patients. Various toxins, biliary enteric drainage procedures, inflammatory bowel disease, asbestosis, smoking, chronic pancreatitis. So a little bit about diagnosis, and I think especially for the Hilar ones, we'll talk about it in more detail. You've got to have an approach if you get one of these cases in the exam, and I'll talk about it again just now. But so with it, you just got to think, what investigations would you do, and how do these patients present? So intrahepatic cholangiocarcinoma, the patient's going to present with a mass. And obviously the investigations that you would normally do would be a CT scan and or an MRI, either with gadolinium or Primavist. And it's obvious, it's not going to have the imaging features of an hepatocellular carcinoma normally. It often will look very much like a metastasis, but often it's a singular lesion. And like I said, you often get capsular retraction. You need to rule out a primary at another site. So these patients need a colonoscopy, a gastroscopy, a breast examination. You're going to do tumor markers, and you're going to do bloods looking for risk factors for liver disease. Okay. If you don't find any any other, or you don't find a primary lesion and it looks like a adenocarcinoma, it's hypervascular, you're not going to be sure, but cholangiocarcinoma is going to be on your differential diagnosis. And then if it's resectable, you're probably going to resect it. And if it's not resectable and the patient's potentially a chemo candidate, then you'll probably do a liver biopsy. Hilar cholangiocarcinomas, the investigations that you would do would be a CT scan, MRI, MRCP. You could do brushings, you could do cholangioscopy, tumor markers. You're going to rule out other things, and I'll talk about that more. So an IgG4 might be useful, HIV. You might want to do a colonoscopy to rule out inflammatory bowel disease. And then the distal cholangiocarcinomas are going to be just presented as a distal CBD stricture. And there's not going to be a mass. There's often not going to be pancreatic duct dilatation. You're going to do tumor markers. You might do an IgG4. You might do an ERCP with brushings and an EUS. So this is just a little bit more. I stole this slide from Sean Burmeister. So, usually your invasive procedures are going to be reserved for when the patients are having a decompression and having biliary drainage. So EUS is generally better for looking at the distal bile duct, looking for mass in the pancreas. ERCP, like I said, can do brushings, and cholangioscopy is usually better for the sort of hilar lesions. So this slide, I know there's a lot of things in this, but it's probably just worth taking a picture and having this as a differential diagnosis for hilar strictures. Okay, so when you're faced with a hilar stricture, one of the things it could be is a cholangiocarcinoma, but there's a long list of things that it could be. It could be a dominant stricture in a patient with primary sclerosing cholangitis, hepatolithiasis with recurrent pyogenic cholangitis, Maritzi syndrome. It can be due to some inflammatory process, IgG4 cholangiopathy, xanthogranulomatous cholangitis, sarcoidosis, long list, HIV cholangiopathy, TB, portal biliopathy, it can be a iatrogenic thing after surgery. A gallbladder cancer can often cause a hilar stricture. So it's good to have a differential diagnosis in your head and just think, you can often rule out a lot of those things, but it's important to rule them out. So I'm going to come back to that. But then I just want to go into the treatment options for each of the different types of cholangiocarcinoma. So with intrahepatic cholangiocarcinoma, as I said, if it's resectable, you're going to do a liver resection. If it's not resectable, you're going to consider doing a biopsy. The biopsy would mainly be indicated if you're going to consider some type of therapy like chemotherapy or local regional therapy such as stereotactic radiotherapy, which is often not available in state hospitals, but it's something that you can give to a patient who's maybe just got one lesion but it's not fit for a liver resection. And then obviously combined with that, there should be a palliative care team involved as well, because these patients are being managed with palliative intent. Hilar cholangiocarcinoma, so these patients are going to present usually jaundiced. And the first step in these patients is going to be to see if you can achieve biliary drainage, and I'll talk about that. And then, so that's usually the first thing, and that can be quite a challenge. You then also need to consider, are they a resection candidate? Are they fit for a resection? Is it possible to get a resection? And what that comes down to is, are you going to be able to get a clear margin with having an adequate functional liver remnant? Okay, and so this usually involves quite a significant liver resection, and we usually like to resect the caudate lobe with a hilar cholangiocarcinoma, because that has been shown to improve survival. So I just want to go back. There's now evidence for adjuvant capecitabine, and we'll talk about that. So surgical resection is followed by adjuvant therapy. If they're not a resection candidate, you have to consider whether they're transplant candidates. And I'll talk also about what are the transplant criteria. If they are a transplant candidate, they're going to get neoadjuvant therapy, hopefully followed by liver transplant. And if they're not a transplant candidate, then it's palliative therapy. And that could just be the stenting. It could be radiotherapy, chemotherapy, and maybe one of the newer molecular targeted therapies. Sorry. Okay. So this, if you think about a hilar cholangiocarcinoma, you're going to have a patient with jaundice and a hilar stricture. 75 to 80% of the time, that is going to be a cholangiocarcinoma. Okay. So what can you do to try and be sure? So you can take a history to rule out certain things. So is there a history of previous surgery? Could this be iatrogenic? Has the patient had breast cancer or some other malignancy before? Could this be related to that? Does the patient have inflammatory bowel disease? Are they at risk of having primary sclerosing cholangitis? Could this be HIV or TB related? Has the patient previously had radiotherapy? Is there stone disease? Could it be a Meruti syndrome? You know, how long is the history? Is the jaundice fluctuating or progressive? Those are all things that give you a clue as to the diagnosis. So you're going to need to do a CA 19.9. You should do an IgG4, and you're going to get a CT scan and the MRI. So malignant strictures tend to be associated with high bilirubin and ALK phos levels. Raised CA 19.9 increases the chance, and it's important to remember that IgG4 cholangiopathy can mimic cholangiocarcinoma. Okay, so with the hilar cholangiocarcinomas, you're going to be faced with a biliary stricture where you need to get biliary drainage. You're not going to be sure in the beginning whether it's a cholangiocarcinoma or not. You need to think when you're getting your biliary drainage, are you going to do brushings? Are you going to do cholangioscopy? You must always do your diagnostic things at the time of your first procedure to get when you're trying to get biliary drainage, because a stent can really make things more complicated later on. Okay, so just coming now to the distal cholangiocarcinomas. If the patient is a resection candidate, they should be considered for pancreatic duodenectomy. In this group of patients, there's no evidence for neoadjuvant chemotherapy. There is evidence for adjuvant therapy, and it's the same evidence that we have for the hilar strictures. Palliative therapy would consist of a palliative stent and potentially chemotherapy or radiotherapy. Okay, so I keep on talking about the adjuvant therapy, and I think one of the things that you could very easily be asked is, what is the evidence for adjuvant therapy for patients with cholangiocarcinomas? And it's not actually very good. Everyone talks about this Bill Cap study, and it was a study that was done in the UK, and they included patients who had a resected biliary tract cancer. So that included gallbladder cancers and extra, my understanding, it didn't include intrahepatic cholangiocarcinomas, although I stand to be corrected on that. And the main primary endpoint was overall survival. And the control arm, they just got observation. There was 205 patients. The treatment arm, they got capecitabine. Sorry, I'm going the wrong way. And basically, there was better survival in the capecitabine group. But if you look at the p-value, it wasn't actually significant. So there was a trend towards improved survival in the capecitabine group. But based on this study, we now offer these patients capecitabine usually for 6 months after resection. Okay. So I thought at this point, we could just discuss a case. I've given the imaging to Yalda, so I'll show the imaging, but Yalda can just talk us through it when we get there. So it's a 56-year-old who I managed in 2017. He presented, he was on holiday, and he developed obstructive jaundice. He was a very fit guy. So when I first saw him, he was jaundiced. We managed to get biliary drainage, although there was quite some challenges, as they often are with these patients. He got cholangitis and was sick for a while, but we eventually sorted it out. And after the the you know, by the 11th of August, his CA 90.9 has dropped from 583 to 276. Yelda, I'm going to just go through the scans. This is the arterial phase. Which one do you want me to show first?
I think it was more clear in the portovenous phase, Mark.
Okay, I'll go to the portal venous phase. So what maybe you want to just talk us through what you saw?
Sure. We are still in the arterial phase. We were having.
Sorry. Okay, I think that's portal venous now, eh?
Yeah. So the portovenous phase.
That was a test. You passed that test. Well done.
Thank you. So there is an intrahepatic biliary dilation. The left lobe of the liver is atrophic, almost gone. Almost there is nothing, and there is actually there is a small remnant of the left lobe with some congested dilated bile duct there. It looks a little bit tortuous comparing to the right side. I think it's just because of the overlapping, and they are not communicating with the right. At that area, I think I saw something which looks like a mass forming cholangio at the area where the level of obstruction is. Yeah, that one. Which is not very, yeah. And for me, it looks more of bismuth 3 or even 4. Considering the left side as well. It's very close to the main portal vein, that mass. There is no very clear plane of separation, but there is like a very thin layer of fat between the portal vein and that mass. When I looked at the arterial phase, the mass is less clear, but considering where it was in the portovenous phase, I think the right hepatic artery, it's a Michel's one. I didn't find any accessories or unusual origin. So I think that the hepatic artery is kind of either very close or kind of running inside the mass itself. I couldn't visualize the left hepatic vein. The vein, I just saw and then I think there was an extra Makuchi vein at the end, if you go further down.
Yeah. So that can sometimes be quite important if you're trying to just leave someone with the posterior segments on the right. I agree with you. You don't really see a left vein at all, and that's probably why we've got an atrophic left side. So, yeah. And he has the MRCP. I'm not actually sure if it adds very much. I think it adds a bit of, I actually thought it made it a bit more confusing, but I don't know if you want to say anything about it.
Yeah, I mean, in here, it's again, like the third picture that you showed, it shows that the duct is not clearly communicating. There is, it's not involving the cystic duct, the gallbladder is filling.
Yeah. So with so bearing in mind what I've said about these things, how would you manage this patient initially? So I said to you that we did get preoperative biliary drainage, but what should you probably do at the preoperative biliary drainage?
So make sure that the patient is basically covered with the antibiotic, not cholangitic. And then when we're draining the biliary drainage, if you're using, I will attempt using an ERCP route, minimal contrast injection into the bile duct. And if it's possible to mainly aim to drain the future liver remnant. In this case, I think it's going to be the right side of the liver.
Yeah. Okay, so so I think if you look in some of the literature, and certainly in the transplant list literature, they say that the diagnosis of a hilar cholangiocarcinoma can be made if you have a positive biopsy or cytology that's positive, some people use this fluorescent in situ hybridization, but that's not available everywhere, and we don't have it available, so that's not practical. If there's a mass-forming lesion on the CT scan or MRI at the stricture, some units would say that that's enough to be certain, although you're not going to be 100% certain. And then also if there's an elevated CA 19.9. So sometimes you're going to have ruled out all the differential diagnoses. You might have a biopsy or cytology that's negative, but the problem is that certainly cytology has a poor sensitivity. Okay, targeted biopsies increase the sensitivity, but it's still only about 74-75% of combined with brushings. So if you do a cholangioscopy and brushings and they're negative, you could still be dealing with a cholangiocarcinoma, and sometimes you're going to have to try and treat it as such. Now, this patient is not resectable, and to be resectable, the reason why this patient's not resectable is there's sexual duct involvement on the right, and there's atrophy and portal vein involvement on the left. So you can't resect this with an adequate functional liver remnant. Okay. So the next thing would be, is this patient a transplant candidate? Okay. So if you think of what I said. So the inclusion criteria, and this is the Mayo Clinic protocol, and it might have changed in some places, but it essentially comes down to there must be no metastases in the liver, there must be no extrahepatic metastases, and the tumor diameter must be less than 3 centimeters. Okay, and it must obviously be irresectable. If you meet those criteria and you don't have any of these exclusion criteria, then you would go on to get this Mayo Clinic protocol, which is external beam radiotherapy, brachytherapy, and then capecitabine until the time of transplantation. So this gentleman that we had, and then the other thing is, at some point, you've got to have a laparotomy for staging purposes. And basically what you do there is you look for extrahepatic disease. If there's any nodal disease outside the liver, you don't transplant the patient. So what we did with this guy, he was very fit, is we gave him external beam radiotherapy. We did intraluminal radiofrequency ablation to the tumor, and we stented him. And then he got capecitabine, he got listed for transplant. And then we got a liver for him, and we did at the time, we did a laparotomy, and we sent off the nodes in the pataduodenal ligament, and there was tumor in some of those nodes. So that liver ended up going to someone else. And this guy survived for about 3 or 4 years after that. So that's sort of how the transplant situation works for these patients. So a significant proportion of them who you plan to transplant don't always get to transplant. So another big topic when it comes to the Hilar cholangiocarcinoma is biliary drainage and the risk of cholangitis. And you have to realize that for some of these patients, it's really just not possible to get biliary drainage. If you've got involvement of the second or third order ducts bilaterally, sometimes all you're going to achieve by trying to get biliary drainage is you're going to cause cholangitis. The important thing here, and there has to be rules when you're draining Hilar strictures, just about anyone can put a stent in for a distal stricture. Hilar strictures are like the difficult thing in biliary drainage. So it's often useful to have an MRCP that provides you with a roadmap so you know what you're planning to drain beforehand. And you cannot get contrast into segments that you can't drain. If you do that, these patients get cholangitis and they die. What you sometimes see happens is someone goes and blows up a balloon at the bottom of the bile duct and fills the entire liver, all the segments, with contrast, and those patients inevitably die from cholangitis. You cannot do that. You got to plan. If there's a Hilar stricture, you got to plan what you're going to do beforehand. And there's a whole debate about whether ERCP or PTC is better. The Dutch recently did a study where they were a randomized study where they were comparing ERCP to PTC, and it had to be stopped early because the PTC arm had a higher mortality. I think there's certainly in our unit a trend towards trying to do more of these cases with ERCP because you can potentially access all the ducts from below, but I don't think it's one or the other. I think often you want to do like a combined procedure where you might want to drain certain things endoscopically and certain things percutaneously. So you also got to be clear of your goal of biliary drainage. So is your goal a bridge to surgery? Then you're going to usually use plastic stents only, or are you just trying to bridge or palliate the patient? And then you may need to just drain 30% of the liver to get adequate relief of the jaundice. As I've said, the evidence when combining PTC and ERCP is, if you get asked about this, I think you must just say that there's so many confounders, it's difficult to be certain. And, you know, some studies have only included resectable patients, some have included resectable and palliative patients. Is the internalization done with stents or not? Some studies use plastic stents, others use metal stents, different endpoints. So there's really not good evidence. And like I said, I think they're complementary, and it's more important to stick to the rules. So the rules are, you do not cannulate or fill what you're not going to be able to drain. You drain any duct that you cannulate or fill with contrast. And you must maintain access, and you may have to use multiple guide wires. So I have an example of a case here that Professor Jonas did. So there was separation of the right and left ducts, and of the sexual ducts on the right hand side. And this patient had a ERCP. Sorry, it started off with a PTC, and you can see that they got contrast into these ducts here, which means that those ducts now need to be drained. And I think this shows quite nicely how a complementary approach via PTC and ERCP can be useful in these cases. So you can see what's happened here now is Prof has stuck up a wire into the anterior sexual ducts on the right, and those are quite difficult ducts to access percutaneously. We have access to the posterior sexual duct on the right via this percutaneous catheter, and the left ducts via this percutaneous catheter. You can now see that busy dilating up the tract, and that's another thing that you should always do with the hilar cholangiocarcinomas. Try and dilate up the tracts with a balloon before you stick in the stents. And what's very useful are the Boston Hurricane balloons. They really work nicely for this. So there you can see now there's a stent into that anterior sexual duct. You can see where the wasting is. You can see there's now a wire going up the left duct. There's now a metal stent going up the left duct. And now the PTC has been retracted on the right into the posterior duct. And you can see that a wire is now being placed down that side. And that's the end result. So you've got to have a plan, and you have to drain every single segment that you get into, and you've got to have that plan up front. And sometimes it's better not to drain if you're not going to be able to stick to the rules. So that's basically what I had to say about cholangiocarcinomas. I don't know if anyone has any questions. So I'm just going to go to the chat. No questions. Wanga, Yalda, no questions.
No.
All right.
Maybe one question. Mark, regarding the transplant, is it, I know some people are going toward the transplant for hilar cholangio, but is it something that everyone is doing? Is it in the guidelines? Or because I read some of the studies that it says that the evidence for the transplant and the survival disease.
So I think that that not all transplant units transplant for hilar cholangiocarcinomas. And I think there's quite a high dropout rate of patients who are listed for transplant. I know that in South Africa, the Donald Gordon group have done transplants for Hilar Cholangiocarcinoma. We've had one patient that we've listed for Hilar Cholangiocarcinoma and only one that we ended up, well, and we never transplanted him. We got a liver for him, but I told you the whole story of what happened. So I think you need to know about it, and I think that that you need to know what the criteria are, and it is something that we would consider offering, but it's only going to be offered to patients who are not resectable, and have a mass that's smaller than 30 millimeters, and you have to go through the neoadjuvant therapy. One thing that I didn't mention about, I didn't go into the details of the surgical resections for Hilar cholangiomas, but those are probably the most technically difficult liver resections that we do, and the mortality rate was more than double than it is for colorectal liver metastases. And it's just something to bear in mind. These can be really, really tricky, difficult liver resections, and obviously you're going to have a biliary enteric anastomosis, in addition to your liver resection.
Mm-hmm.
Hello. Evening, Marc.
Hi.
Thank you. Very interesting presentation. My name is Chikwendo from Johannesburg.
How's it?
I've got two questions. One is maybe a stupid one, but why you don't transplant intrahepatic cholangio?
Okay. So it's a good question. And you'd think, why not do it like we transplant HCC, and we transplant, people are now transplanting sometimes for colorectal liver metastases. So it's interesting. Jean Boerter worked at, before he came back to Donald Gordon, he worked at the Nebraska Medical Center, which is in Omaha, which is like a small little place in the middle of America, but it has a very busy transplant unit, and they're very aggressive surgeons there. And they were actually, although it's called the Mayo Protocol, they were the first hospital that really started transplanting for Hilar cholangiomas, and then the Mayo guys sort of jumped onto that afterwards. And in the beginning, they did do some transplants for some small intrahepatic cholangiomas, and they also did transplants for some patients who had Hilar cholangiomas with a little metastases. And the results are just dismal. Almost all of those patients develop metastases quite soon afterwards. The 5-year survival, if you transplant for intrahepatic cholangiocarcinoma, is less than 20%. So it's just because the survival is so poor.
And that's where my second question now comes. Now you've got a patient with a central mass, all right, and it's resectable, all right. Now, how do you differentiate? Okay, let's say it's not resectable, but the patient is a transplant patient. How do you differentiate an intrahepatic cholangio that is there in the central region to a perihilar cholangio?
So I think usually, like a typical intrahepatic cholangiocarcinoma, so it all depends on what order ducts you think it's arising from. So if you think it's arising from proximal to the sectoral ducts, the anterior and posterior sectoral ducts, so if the stricture is there and there's only one mass, then it's a Hilar cholangiocarcinoma, basically. So if it's central and it's right by the right and left hepatic ducts, then you would classify that as Hilar. And if it's once the mass gets bigger than 3 centimeters, then it's not a transplant candidate anyway. So usually an intrahepatic cholangiocarcinoma in that area, I think, would be bigger if it was intrahepatic. So I don't think it's usually a problem. Like, I don't think it's like a clinical problem that we often have to worry about. If it's in the Hilar area and the mass is less than 3 centimeters, then we would consider the patient as a transplant candidate.
Thank you.
So when you get a case like this in exam, I think often, I was just saying to Yelda beforehand, like, you can get a bit stressed out. You get a Hilar stricture. No one knows for sure whether it's a Hilar cholangiocarcinoma in the beginning, okay? And your examiners can't expect you to know that either. So, you can say, you're going to look at, does it look malignant? Okay. You can say you're going to look at the CA 19.9. You can say you're going to do cholangioscopy and brushings. But even if the cholangioscopy and brushings are negative, as I've said, it could still be a hilar cholangio. So you've got to have that differential diagnosis in your head and say you're going to rule out as many of those things as you can. And then take it from there. So I want to just give you another example. So I spent some time in Omaha in 2012 before Jean Buerta came back, and it was quite interesting. So they had a patient with primary sclerosing cholangitis. Okay, so patients with primary sclerosing cholangitis sometimes get a hilar stricture, and the query is it a hilar cholangiocarcinoma? And the patient had a slightly elevated CA 90.9, and they did brushings, and they did the fish, and the fish suggested that it was malignant. So they did the whole Mayo protocol, and the patient got transplanted. And I remember it's one of the transplants that I was at when I thought, sheesh, I remember the patient got a donor from the donor was about 70 years old. And I remember thinking, yes, this is one of the few transplants where the liver that we're taking out doesn't look that much worse than the liver that we're putting in. And the histology came back that they didn't see any cancer in the hilar area. And you could argue, well, maybe it was a complete response to the radiotherapy and the chemotherapy. But it's one of the problems with hilar cholangiocarcinomas is that it's sometimes difficult to be sure, and you certainly don't want to transplant someone if you're not sure. So like the patient that we listed for a transplant, we had a positive cholangioscopy biopsy. But sometimes you're going to get to a point where you've done all your investigations and you're still not 100% sure. And sometimes you have to make a decision about whether you're going to subject the person to a major resection or not, based on the evidence that you have. And that's often a discussion that you can have. Any other questions?
Hi, Mark. This is Samani from Johannesburg.
Yes.
Thank you for this thoughtful discussion. But just taking the last talk about the the patients who had been transplanted and then the biopsy came negative. Is it really a negative pathology? No, that means no cancer primarily, or is it kind of complete pathological response?
Well, you see, you don't know that. I must say, I was wondering whether, see, the thing is, in a patient with PSC who now has a dominant stricture, you could argue that eventually that patient is going to need a transplant anyway. So it's not the end of the world if they get their transplant a bit sooner. But you know, you will never know if it was a complete pathological response. But you know, I don't know. But it just left me with a funny feeling, thinking that maybe this patient got a transplant for cancer and then maybe never had a cancer. And that is the problem with hilar cholangiocarcinomas. I've been involved in resections where we went in thinking it was a cancer, and you do an extended hepatectomy and it comes back as a benign stricture. You could argue, well, you've sorted out the stricture, but you know, you're not always 100% sure. You can do all the investigations, but because the sensitivity is only about 75%, a negative biopsy doesn't rule out a cancer. And I'm sure a lot of you have seen patients who've had metal stents put in for a hilar cholangiocarcinoma who 2-3 years down the line are still alive. And now you've got this problem of recurrent cholangitis. It's another problem is putting in metal stents in patients without a positive biopsy of cancer. A proportion of those patients won't have a cancer, and you can end up in a big problem down the line from the metal stents. So yeah, it's a very tricky part of HPB surgery, and it's often good to manage these patients in an NDT environment, and that's something that you can say in your exam as well.
Sorry, Mark. But you can have it the other way around too, where you have done a limited surgery, thinking that you have a benign disease, and then it comes back as cancer. So what do? Let's say somebody has done.
I think exactly. So I think, you know, you got to go through. That's why also you must plan to do your investigations early on for hilar strictures. remember what I said, it's important to have that MRI ideally in the beginning and to do your investigations. If you're going to do cholangioscopy, you should plan to do it at your first thing. If you're going to do brushings, do it before you put a stent in. You know, have a good look at what it looks like. You don't want to go and do a hep jedge for a cancer when the patient actually needs a resection. So if you don't find any other cause and you've got a high incidence and it looks like a malignant stricture, then you're going to have to treat it like that. But about 5% of the time, you're going to get it wrong.
Thank you.
Just another question. That's just I'm just asking about you thought about the preoperative augmentation of the future liver remnant,
Yes.
especially if you have any kind of background liver disease. So what's your thought about that?
So with a Hilar Cholangiocarcinoma, well, with anything, you want to probably have a liver remnant of about 30%. And often these patients need an extended hepatectomy. So they often do need a portal vein embolization. Like I said, there's a whole debate about, so I think you should definitely have the functional liver remnant drained. I know that Professor Jonas believes that we should also drain as much of the side that you're going to take out as you can, and as much of the side that you're going to do the portal vein embolization on, because there's a potentially higher chance that you get an abscess or infection on the side that you're going to do the portal vein embolization on if you don't have biliary drainage on that side. So we often would, if we're going to plan to do portal vein embolization, we'll drain the future liver remnant and we'll try and drain the side where we're doing the drainage. But that's not always possible because sometimes you have quite significant sectoral duct involvement and it makes drainage on that side difficult. And you've got to stick to those drainage rules that I mentioned. If you're going to put contrast into something, you have to get a stent into it.
Thank you. Thank you for that. Thank you.
Okay, is that it? I think so. All right. Thanks, everyone. So next week, well, I just want to say, so next week, Professor Jonas is going to be giving a talk on the management of colorectal liver metastases. So I just wanted to finish off by saying thank you to the ECHO University of New Mexico and ECHO India team for their support. There's a feedback form available in the chat, and recordings will be available on the Gastro Foundation website. And also thanks to the Gastro Foundation. Thank you, everyone.
Thank you.